Thank you for joining us for our webinar series, Unlocking Hormonal Health, Proven Strategies for Practitioners. The presentation will begin in a moment. The presentation will begin in a moment.
Hey everyone, excited to be here. Thank you so much for joining us for this part 2 of the Endocrine Masterclass series. And I am Michael Chapman. I'm a naturopathic doctor. I'm the Director of Product Innovation actually here at Genova Diagnostics. And excited to be sharing this talk with you and this series with you. Happy to be part of it. And again, just thank you for your attention and dedicated to learning. So I'm going to be talking about what we're calling the next generation of hormone assessment. And the reason I think why kind of talking about it in this way is because there's just so much difficulty in understanding how we assess, measure levels of hormones, whether that be the sex hormones, whether that be looking at HPA axis function to assess stress. There's so many different opinions out there as far as the optimal way to address this topic and how to use testing to really kind of guide your intervention and your, whether that's bioidentical hormone replacement therapy, whether that's diet, nutrition, supplementation, all of those things. How do we understand the complete picture? And the subtitle of this, I'm saying applying the correct tool for the question, because I think at the end of the day, you'll find that there is no one best test for every situation. And really, what we're driving towards as clinicians and here at Genova as a lab is trying to provide tools that are going to allow you to not just use a one-stop shop for all of your patients around hormones, because just like your interventions are tailored to each patient in front of you, so should the tools you're using to figure out their key dysfunctions. And that's kind of the focus of my part of this series, and hopefully I'll be contributing some good information for you all at home. So with all that said, some of the main things we're going to talk about, I hit on them just a second ago, but the pros and cons of different testing options, whether that be serum, saliva, urinary hormone testing. I want to get into some of the assumptions that we have around hormone testing as well. There are a lot of different things you will hear out there in the functional integrative medicine space. And so, is there room to challenge some of these, or where can we really hang our hat? Definitely want to talk about which tests might best serve your specific patient and their needs. And then lastly, kind of think about some of these best practices around hormone testing, which leads me to this great quote that I think encapsulates a lot of the discussion around hormone testing, ironically. And even more ironically, this quote, which is often attributed to Mark Twain, wasn't even from Mark Twain. It ain't what you don't know that gets you in trouble. It's what you know for sure that just ain't so. Scholars now suggest that it was actually another famous writer, Josh Billings. But then other scholars determined that that was unlikely, and there's been about 5 other suggestions. So again, ironically, we don't know who said it, but that being the case, I might as well just claim it for my own, since we can't have an agreement here. We've learned a lot already about hormones, some of the symptoms of hormone imbalance, and so we're not going to spend a ton of time belaboring this slide. You can see there's tons of different manifestations of hormone imbalance all across the board. And so what I will say is that I think before you decide to run any lab test, it's important to figure out why you want to run it. There's a difference between even checking someone's baseline levels before treatment with something like BHRT, as compared to just having a follow-up test to manage their dose or even changing what hormones they are on. So really think about what knowledge you're trying to glean from the test that you're ordering, because I think that's really going to help you narrow down which tool is the best one for the job. And again, hormones are all about balance, right? They don't operate in silos. They're always impacting each other. Sex hormones impact thyroid, thyroid impacts cortisol, cortisol impacts sex hormones, and on and on. We have kind of this simplistic visualization of a pyramid to kind of just give a basic layout of perhaps at the base and the bottom, the most fundamental is metabolism, which we'll talk about in just a second. But HPA axis is directly related and can impact thyroid. Thyroid can impact sex hormones. We know these things kind of stack on top of each other, but it is also bidirectional too, right? I think Dr. Smith mentioned that, and I wanted to emphasize how important it is to not think of these hormones as being in silos. So that's why we often talk about introducing hormones and hormone replacement therapy slowly and in small increments, because they're always affecting each other. Even if you're just giving something like testosterone, what impact is that having on the rest of the system, right? If you have kind of this spider web of interrelated hormones talking to each other, even small little doses can really have a dramatic impact. And at the end of the day, every patient's gonna have different needs. So don't just listen to the symptom picture, and don't just treat a number on a lab report. You've got to combine all of that information into one assessment and have it make sense with the patient sitting in front of you, right? But just to spend a minute on the base of that pyramid that we have there, metabolic flexibility is hugely important. And we could have an entire series on metabolic health and leptin and ghrelin pathways and all these fun things, but that's not the focus today. We don't have time for that here. I would say that if you are working with a patient around managing their hormones and you aren't discussing metabolic health, I mean, you're kind of like a cat chasing its tail. You're never going to get them to a stable place in hormone supplementation or management without including metabolic health as a bit of a foundation. And what is metabolic health? I like to think at the end of the day that metabolic health is all about energy management. The body's not designed to operate, as I have listed here, on the same percentages of macronutrients all the time. It likes stress. That's where the flexibility comes from. The body is used to having periods of time when it has access to glucose, when it has low access to carbohydrates and higher access to fat, protein. And so it likes to have energy coming from different sources, and it likes to push and pull on these different levers to actually use the systems that it has available. If you're looking into metabolic flexibility and metabolic health for your patients, just some key markers that I'm listing off here, like the triglyceride to HDL ratio is a tremendous marker for overall insulin resistance, insulin sensitivity, and progression of insulin resistance. Fasting insulin, of course, uric acid is an important marker, and then certainly as it relates to metabolic health leading into cardiovascular disease is where you want to look at markers for inflammation and oxidative stress. And that's kind of very simplistically putting these things together, but there you go. There's metabolic flexibility in a couple minutes. The next layer, the next tier of this cake, HPA axis and adrenal function. And many of us tend to have a very myopic version of how we interpret stress and clinical cortisol dysfunction. We think of this one-to-one relationship between either acute and chronic stress and cortisol, right? It's like stress, cortisol. But keep in mind the relationship around inflammation and infection as well with cortisol. There's a huge propensity for people who have inflammation or an acute infection or even a chronic infection to have higher levels of cortisol. And I like to also make one kind of key point around stress, because what do you think of when you think of poor adrenal function? You think of stress. But what we don't actually talk about much is the definition of stress. Where does it come from? Why do we get stressed? And so I always just like to put in this little nugget of stress is actually, at its root core, it's life events that are outside what our daily expectations have prepared us for. And I do think that this is important because we have different kind of set points of how flexible, use that word again, how flexible we are with unexpected events. Some people can have the slightest little alteration in their schedule and it leads to a tremendous amount of stress, a tremendous amount of cortisol. Other people might not have that sort of low bar of expectations, and when things change, they're able to adapt pretty quickly. And that's another way that personalized medicine can really help manage stress. We tend to, sure, we can give all of our ashwagandhas and all of our eh, therapeutics to help lower stress. We can talk about mindfulness techniques and stress reduction strategies. But if you really want to think about root cause medicine, also helping the patient get to this place of learning where the stress is coming from. And this could be even in the form of recommending counseling or something like that, where I'm a big fan of counseling to help people understand where their expectations and their failed expectations are leading them to on a physiologic level. Because we're all going to have surprises in our lives. We're all going to have stress, and sometimes it's big stress, sometimes it's just little daily stress all the time. And getting through that is another way we want to think about a root cause approach to managing HPA axis function. Of course, supporting with all the tools that we have from a therapeutic standpoint. But man, this is when you think about therapeutics, you got to think about therapy too, right? I mentioned inflammation as well and infection, but one thing that I keep coming back to with respect to the adrenal gland, what the function of this adrenal system is, and managing expectations. One wonderful tool, which seems kind of odd for helping to assist, support the adrenal gland and the HPA axis, is actually routine. Right, I just mentioned that stress comes from some unexpected surprise, something that you weren't prepared for and is generating some sort of change deviation. Routine is sort of the antidote, right? People have varying degrees of commitment to routine, but this is hugely important. Even establishing a bedtime routine or a wake up routine really helps prime the system for not only helping it rest and feel like it knows its place and knows where it's safe and knows what's going to happen in the next 30 minutes, but also long term makes us more flexible for when things do pop up. And so here we go. This is just a plug for some basic things that you don't even have to have your patients spend money on fancy supplements for. It's a conversation about introducing more routine in their day to day. On the testing front, you can certainly use cortisol measurements to say, oh, it looks like you have stress. And usually when I say this to patients, they're like, I didn't need to test to tell me that I'm stressed. I kind of know, I experience my own life. So I think a better use of time of testing is to think about the sequelae of stress, which is how is it being balanced with androgens and the risk of developing catabolic physiology. And so catabolic physiology, we think about things like osteopenia, sarcopenia, immune suppression, weight gain, water retention, low libido, right? These are all downstream effects of chronic stress. So focusing on, hey, you've got this going on, you have this going on, let's address this as much as possible so that at the end of the day, we're not sitting around worrying about osteopenia, osteoporosis. And keep in mind that androgens serve the opposite role of cortisol. Right? Cortisol is sort of our breakdown, our catabolic hormone. Androgens are our anabolic hormone, which is why we have on this test this sort of teeter-totter balance between anabolic and catabolic balance. Where is the patient falling in that spectrum? So don't just look at the hormones in isolation, right? Like look at how they're relating together around the anabolic catabolic balance. Then moving up to that next tier, many of us have a pretty good grasp on how to evaluate and manage thyroid complaints and issues, especially if you've been in functional medicine, integrative medicine for a while. I don't have to spend a ton of time speaking about the thyroid, but I do want to mention one thing about understanding the role of the thyroid and how it's part of this picture. So the big picture of the thyroid in my mind is it's kind of like a cellular thermostat, whereas metabolic flexibility was a little bit more of energy management at a high level throughout the whole system. Now we're talking about with the thyroid, we're talking right down to the cell. What is the overall thermostat? It serves as kind of this upstream regulator of anabolic energy usage, meaning thermal regulation, tissue growth and repair, right? Providing kind of that fire for tissue growth and repair. And then also tissue sensitivity. By that, I mean, just like we have with insulin resistance and insulin sensitivity, we also have tissue sensitivity to our thyroid hormones too. So, what's been kind of the long stream tissue sensitivity for this patient to something like a T3? And keep in mind that the thyroid is highly susceptible to cortisol and adrenaline. These two things have a direct feedback mechanism where higher levels of cortisol tend to inhibit the stimulation of the thyroid and the conversion of T4 to T3 and all those different kind of interwoven links. So that's why we have thyroid kind of sitting on top of HPA axis function, because if you could have a perfectly normally working thyroid system, but if you've got an imbalance on that HPA axis side, you've got it already off kilter. All right, so then let's talk a little bit about the sex hormones and the top of the pyramid, how to manage these. Because I will say that, I think a lot of us are here probably to think about how we're implementing testing in things like bioidentical hormone replacement therapy. So, how do we address sex hormones? What are we looking at? What are we using? I first, before we even talk about testing, would say understand the system as a whole, right? Take a step back and think about inputs versus outputs. Because it's not just a hormone and that's it. We have the production of the hormone, we have how that hormone is being transported throughout the body, how it's being utilized. What's the tissue sensitivity? Again, at the receptor level of the cell is going to have an impact on how much hormone needs or you should be dosing. And then what's the detoxification and elimination? All of these you should be thinking about before you're even writing down the dosage for the compounding pharmacy or wherever you're potentially ordering intervention in hormones. So if we want to dive into really understanding hormones, this chart really helps us take kind of this wide view. And you can even think about with production of hormones coming from cholesterol, being controlled by the pituitary and mitochondria. This is something we also have to think about, right? Does the patient have adequate cholesterol? Have they been on something like a statin? Are they actually have functioning mitochondria to help convert cholesterol into some of these zoosterols to create their androgens or their estrogens or things of that nature? What's the how is it transported in the body? What's the binding capacity? What are the other things that might impact binding capacity? These are all small little systems that we tend to focus directly on. Is there estrogen? Is there not estrogen? Give it or don't give it, without thinking about all the other factors that might go into why or why not that therapy is working. And just to give a little bit of an example of how complicated this is, these are all the things that can actually regulate the hormone cascade, right? Look on the androgen side, all of these different things that we are exposed to or have to a varying degree, or our patients have, I should say. Estrogens, same deal, insulin resistance, smoking, alcohol intake, PCBs, phytoestrogens, xenoestrogens, inflammation, caffeine, like these are all impacting this entire system, right? And so, holy moly, like, look how complicated this is. And I say that not necessarily to hope to scare people who might be listening, watching this, but really to sort of just set the stage to say, now that you see how complicated it is, let me make the argument for we need to have precise interventions and precise tools to test. Because at the end of the day, if you want to see how all these things are functioning and interacting together, we need to look at the big picture. And this is just one representation of that pathway from the Endo Plus report. You can see kind of how it's all fit together, a little bit more simplified to be honest, but you can see on your patients, if you order this testing, how one of these systems is imbalanced versus another and how they're interacting each other. All right, so let's get into sample types and clinical considerations. So discussing the conflicts of interest surrounding each sample type and testing companies. This is one of these things where you have to think about the clinical question being asked. What do we need to learn from this patient or about this patient? And then what are some of the therapeutic modalities being used? Are we using serum, saliva, urine? What are the different things they might be testing us? There's even dried blood spot options out there. And basically, you could always, anything that ChatGPT might come up with in the future, we can stay tuned for a future webinar. So let's start with serum testing. Serum testing reflects circulating hormones, including bound and unbound. And to be honest, the most amount, the highest percentage of hormone circulating in the serum is going to be bound to a great deal. I will say that serum testing has the most literature compared to any other matrix. And with respect to serum, because so much of it is bound, it's important to assess binding capacity. And so when we talk about free hormone versus bound hormone, one thing I think we really want to acknowledge is the different impacts of these binding globulins. So progesterone is primarily bound by this binding protein called corticosteroid binding globulin, and then androgens and estrogens are bound primarily by sex hormone binding globulin. Now, albumin can also bind steroid hormones, however, it has a lower affinity for them, and what it's really tends to be thought of used for is buffering major fluctuations. Because it has this low affinity, it's not as responsible for making sure like the precise amount of the sex steroid is available to the tissues. It more so is trying to address larger swings in production or detoxification. So this paper has done a lot to create some pretty strong opinions about what serum evaluation can be used for, particularly around BHRT, bioidentical hormone replacement therapy. There have been a few other papers that have come out in the past 5 years with funding from various companies, which have tried to support this message. And so let's just spend a second taking a look at this study. So one of the main conclusions that's used from this study often is that the reliance on serum levels of progesterone for monitoring topical dose could lead to an underestimation of tissue levels. So basically what that means is that if you're using serum testing on progesterone and you're giving some sort of intervention, you could have basically plenty, you could have lower levels showing up in the serum compared to what's actually being used in the tissues. And where they got there was they had participants that had been on topical progesterone for 2 weeks, and they did testing on the last day of the study, right? So patients take progesterone 2 weeks, and then last day of the 2 weeks they do testing, and they do testing over 24 hours. So there's a few charts from this article that demonstrate the difference in serum progesterone levels versus saliva progesterone levels. And I've highlighted the axes here to demonstrate the difference in concentration of the hormones. In the blood, it looks like baseline is around kind of a 0.5-ish. And it only goes up to say like a 0.6, if you can see there at the 10-hour window. And the saliva actually on the right-hand side starts out at a baseline from around, what is that, about a 2 for the cream, and then jumps up to like a 3.5. So you see a bit of a more dramatic spike here in the saliva on that last day after dosing as compared to the serum. But what I want to say in part is that this is a very important study because it's the main study that's referenced around claims that topical hormones and likely other topical hormones, not just progesterone, don't show up in the serum. Because on the left, you don't see much of a change as compared to the right, where you see this kind of nice spike and then it sort of peters back out. And so I will say the inference here in the serum going from a 0.5 to 0.6, whereas the saliva almost doubled, I would say that the raw concentration of an analyte, like progesterone, doesn't necessarily tell you the entire picture, right? It doesn't imply like you must only use the measurable analytes in the highest circulating pool. And what I mean by that is like, take for example, a serum magnesium versus an RBC magnesium if you're used to testing magnesium levels. Fluctuations in the serum tend to be much smaller, right? They tend to be within a homeostatically controlled window. So very small moves in the serum can actually represent very large swings. And we know that as compared to RBC magnesium, which tends to be more of a reflection of long-term dietary status. And so just because a zero point 0.5 turns into a zero point 0.6 and it's only a difference of 0.1 does not necessarily mean that that's not statistically significant in any sort of way. So that's one thing I would point out. These things are going to naturally ebb and flow and have different standard deviations for each one of their individual matrices. And that's kind of big, long speak for small moves. Even though it's a small move in the serum, it could mean something very dramatic and very large. So that's one little pushback that I guess I would have. So with respect to single dose limitations, because this was a study where they only looked at 24-hour period after 2 days of intervention. Don't think in terms of best and worst, right? Think of what each measurement is telling you. Is that 0.5 to 0.6 actually relevant of a change? And where in time did they measure that? What are the expectations for the circulation of a hormone in the serum and saliva? Can we still determine normal versus abnormal? And so another paper to address this question around, does topical progesterone show up in serum? It's actually, this is a study from 2000, and even though it does look like it's a study from like the 1940s based on that font, but in this study, they took postmenopausal women who were not on hormones and they gave them a 42-day regimen of topical progesterone. And I think this is a little bit of a better study design because they weren't just looking at 1 day, right? They were looking at a pre-post comparison. And what they found, they actually did a dose dependency as well. As you can see, some people were on 20 milligrams, some people were on 40 milligrams. And what the conclusion was here is very little progesterone could be detected in the serum following a single application of creatine, but progesterone concentrations following 42 days of administration, which is we're not going to have our patients on 1 day dose, right? But after 42 days, they did demonstrate a systemic absorption of the progesterone had occurred and that the mean progesterone concentration was statistically significant. You can see there on day one that sort of the concentration of progesterone was around a 0.7 for the average total, and then it jumped up to a 5.3, which was very statistically significant. Here's another study from 2010, and they actually were trying to prove something interesting, that a 5-alpha reductase was responsible for progesterone metabolism. But they didn't prove that. But again, what they did find as part of the data was, if you look here on the right, the pre-treatment dose as compared to the concentrations of progesterone in the serum at different days in intervention. And you can see it both on this chart here where they compared it to ditusteride and placebo, where before you see very little of progesterone concentration in the serum, and then after a given point of time, it was statistically significantly showing up in the serum. So I don't necessarily think the case is closed on this question of, does topical progesterone show up in serum? We've got clear data here, at least in these 2 different studies, and there are a couple more out there to suggest that yes, in fact, over the course of time, it does show up in the serum. So it leads us to our next question. Even though it shows up in the serum, is that representing tissue levels? And one of the counterpoints here is that because serum progesterone does not increase to premenopausal levels, premenopausal luteal levels, with topicals, meaning if you have a patient or you do a study, you won't see that after normal kind of dosages of topical progesterone that their serum levels are getting back to luteal levels. So I would say, like, this this is another thing that I would question some of the pharmacokinetics or even the intraday levels of the hormones. So we'll talk about that a little bit later with saliva, but some of these studies, there was actually oral progesterone was used, whereas others topical progesterone was used. And this same dosing or even lower dosing of progesterone shows so another one of these arguments is that if you start with something like physiological dosing of progesterone, you will see anti-proliferative endometrial effects in studies, even though the serum levels don't match luteal levels. Meaning, is it necessary for someone's serum levels to be at the luteal range to have anti-proliferative endometrial effects or just systemic effects? And so the answer to what we're seeing in some of the research is that no, actually, you can certainly have anti-proliferative effects with lower serum levels. So I don't know that we should necessarily be keeping this reference range of luteal relevant for dosing in the serum, if that makes sense. They might be 100% different, telling us different things. So another counterpoint is that levels of progesterone found in saliva appear to increase rapidly after application and then return to baseline within 12 to 24 hours. You have a much more dramatic peak in the nadir of that 24 hours after a dose as compared to what you might find in the serum, which we saw in the earlier study. And that kind of makes sense because in the serum, things are buffered with binding globulins, right? And so again, those levels do come closer in the saliva to what looks like regular luteal cycles, but I'm not sure we can make that one-to-one comparison to say, just because this looks like a luteal level in the saliva, that means we're in our sweet zone. And that means that saliva is the only way to assess this. I think that what's really happening here, to just kind of cut to the chase, is that these two things are the serum versus the saliva are telling us two very different stories. And that's what we're trying to do on our end, is piece those stories back together to give even a greater picture of what's going on for your patient. Okay, so with respect to androgens, keep in mind that androgens tend to be more lipophilic than estrogens, and this affects how they travel in the body. So compared to progesterone and some of the stories that you've heard already brought up around the availability of progesterone in the serum and how much we see in the serum after therapy might be very different. Androgens is even a different story based on how they're distributed. Androgens, like our other sex hormones, are tightly bound to sex hormone binding globulin, less so albumin, like I mentioned. And this is a great example. Testosterone, less than 5% of testosterone in the serum is actually free testosterone, and that actually decreases with age. So when there are consistent levels of binding proteins, testosterone is relatively reliable. So this is where we get some of those markers like our free androgen index. One thing that you will find is in some of these studies, actually the clinical applications or the clinical interventions of testosterone and some of our other hormones and some of the symptom presentation might actually be more highly correlated to sex hormone binding globulin than even the hormone concentration itself. So I know some of us will look at sex hormone binding globulin as part of the picture, but many of us don't, or many of us don't even understand the real utility of something like a sex hormone binding globulin. But when I see studies that are starting to show, actually, this is even more correlated to the symptom presentation than even the androgen concentration itself. That's one of those things where you're like, whoa, maybe we should start rethinking about how we're even viewing this picture. You know what I mean? Anyway, so topical testosterone and serum measurements, it is likely to best test within 8 hours of the most recent dose, just based on the pharmacokinetics. So if that is something that you can time, and that brings me to a different important point, which is anytime we're testing our patients, whether that's baseline, follow-up, we should be thinking about not just how is that patient's results comparing to a reference range, but how is that patient comparing to themselves? Because again, everyone's going to have a different physiology, and you will be learning more and doing more for your patient if you're thinking, I want to compare this patient to themselves after therapy as compared to, I want this patient to be within this window of numbers, because that doesn't necessarily make sense based on how different we all are. So just a little plug for, try to get your patient to do the test the same time of the day they did the test, to take their follow-up and their dose the same time they did the previous test. Try to have them reenact and emulate what they did before, so you can get that clean picture of where they were before and where they are now, and that comparison within themselves. So oral androgen, HRT, and serum, Serum levels correlate very strongly with saliva, both intraday and longitudinally. We have seen this with respect to oral. The biggest variability actually occurs at peak levels in saliva, like you saw before. How high that peak goes is the biggest variability between serum and saliva, but across the studies, there is very good correlation, actually. We find this in the research. So same goes for DHEA and DHEAS. DHEAS is typically what's looked at in the serum. DHEA is typically looked at in the saliva, but they do correlate quite well. So I don't think that's a major decision point between saliva and serum if you're trying to decide what method to use. Now, estrogens. Estrogens are even less lipophilic than our androgens, so we tend to have even less confusion compared to progesterone. So with our patients who are not on BHRT, I would say serum is perfectly appropriate way to measure estrogens. And even as you can see here, the jump between estradiol and estrogen was observed and was obvious between days 1 and day 21 following estradiol supplementation. And so now I will say caveat, this study was done with oral estrogens, which most of us are not doing. So I was hard pressed to find another study like this using topical estrogens like a biased. Those studies honestly they're yet to be done, which I think says a lot about where we are, even in our journey of understanding these hormones and how our bioidentical hormone replacement therapy is impacting different matrices, whether it's the serum or the saliva. We definitely need more research on this. And I'll show you that part of the design and the approach of this Endo Plus report was to actually do just that. But that being said, I will show you some patient results. So here's one patient who is both on topical progesterone and estradiol. And I would say in the serum, looks like we're seeing, compared to the reference range, some higher levels of those two hormones. Here is a patient on unopposed topical estrogen, and then here's the third patient who is on progesterone only. And so the point of this, honestly, is to say, I know a lot of us are thinking that you don't see hormones show up in serum, especially topical hormones, but I've got at least some evidence to suggest otherwise. Now, again, that doesn't make a case for it being absolutely so, but that combined with some of the research I showed before, I think we should reevaluate whether some of these things we're saying about whether hormones show up in serum, or particularly topical hormones show up in the serum. Okay, so here is an example of how hormones are changing across age. We have this graphic on the Endo Plus report. This is the serum sex hormone page, and you can see with progesterone and estradiol, the pre-menopausal or even the luteal levels on the left-hand side, that change from luteal to menopausal on the right, in the middle in the gray, and then menopausal ranges on the right-hand side, just to show you a little bit of a visual representation, because we don't always know if your patient is maybe surgically menopausal or what their specific where they are at around their hormones. And so you have the ability to just kind of see that level with respect to various reference ranges that we have available. I will also say that this is not a true representation of of how those are scaled across that chart. We actually tried to do it as a true linear representation, but the levels in menopause are so minimal of both progesterone and estradiol compared to luteal that it was almost like it was falling off a cliff, and it made the chart not very usable. So it's not perfectly linear, but it is functional here for the same purpose, which is to say you can have your patient's results plotted based on the reference ranges. And this is, again, you'll get if you're running the sex hormones on the Endo Plus in the serum, then you're also going to get some sort of score around the sex hormone pillar, which is on the first page. I know Dr. Smith went through the report quite a bit last week, so you should be kind of familiar with how the report works. But again, when you lay all of this out along the pathway, you start to see this larger picture of how that pyramid is, it's kind of set up. And I will say it's a little bit lopsided because the androgens are being driven down at a higher concentration in this patient. And so keep in mind that aromatase is one of those things that will draw down androgens into the estrogens. This is the nice thing about having a chart like this. In this patient, you can see, wow, okay, their estrone is on the higher side, their estradiol's on the lower side, their 2-hydroxys on the lower side. So we're seeing this shunt of the androgens down into the estrogens and then this concentration within esterone. So you really can think about how all of these things are fit together. All right, let's move on to saliva. I would say salivary testing is most useful in a couple situations, right? We want to look at unbound fraction of hormone. We certainly can easily assess diurnal patterns in hormones like cortisol and melatonin in the saliva. It can certainly be used to establish baseline levels before therapy. We'll talk about monitoring. I will say one of the precautions around saliva is gingivitis, right? We probably don't talk about this enough, but because if you're introducing any sort of bleeding blood into the salivary, and it can even be a microscopic amount of blood, can drastically influence the level of hormone in that result because hormones circulate at a higher concentration in the blood than in the saliva. So if you're introducing blood into the saliva, you're throwing that result way off. Should obviously not be used in conjunction with any sort of sublingual hormone treatments. Transdermal can sometimes produce abnormally high levels, and I'll speak about that in a minute. So again, the assumption is that since salivary values tend to reflect those during menstrual phases, like luteal phases, this means that the sample type is more accurate. And we're seeing that show up here again. You're seeing kind of that peak and then that floating off, meaning that what's really being said here is during this peak, that nanogram per mil concentration of a 3.5 or so may actually be closer to what this woman, a luteal level of progesterone. And to be clear, so the time since the last dose has a very large impact. So if yes, you are absolutely capturing that peak based on dosing, then that's one thing we have to keep in mind. But again, going back to making sure you're having your patient run the test at the appropriate time around the last dose they took is going to have a dramatic impact on what your result comes back to be. So you have to control for that recent exposure of hormone to make sure you're capturing that peak, or you try to capture that nadir where maybe after a 12-hour period or a 24-hour period, that hormone has come back down, and that might be different person to person depending on how well they're detoxing. And honestly, I'll say it on the next slide here, how much they're actually secreting hormone into the saliva. This study is amazing. This was done in 2012. It demonstrates that when you controlled for a dried blood spot level, that there's actually a tremendous amount of variability in how much hormone a person secretes into their saliva. Now, is this because dried blood spot doesn't reflect hormone status? Not likely, because here's the thing. These patients were not on hormones. This is at baseline. So what they found was the dried blood spot levels tended to be pretty consistent within a population, within the study participants, but their salivary levels were drastically different. Maybe somebody had 10x times production of progesterone into their saliva as compared to this other participant. There was much more interpersonal variability between the amount of hormone in their saliva compared to the dried blood spot, which tended to kind of be within a regular window. So that's kind of problematic. But I would say the good news is that the study also showed that there was tremendous consistency in how much hormone a given person produced in their saliva, meaning they were consistent with themselves. If they tended to put a lot of hormone into their saliva, they did that across the entire study, which means if you have a patient that seems to be like saliva is a good method for tracking their hormones, then you should be able to use saliva, at any time for follow-up. If you have a patient who has very high salivary levels, might not be a good candidate for salivary hormone testing. And it doesn't matter how many times you run it, they're just going to have sky high hormone levels in the saliva because they might be one of these people who are what we're calling a kind of a super secretor in the saliva. So I want to go back to this saliva equals tissue levels. You may have heard this. There's a lot of assumption that saliva is a tissue itself. The results tend to look like luteal levels more so in the saliva, and that means that that is a reflection of quote unquote tissue levels. That this is the logic here, is that physiologic doses result in symptomatic improvement and histological changes, which is good from tissue biopsies. And physiologic doses can lead to salivary results that approach follicular and luteal levels. Therefore, salivary results reflect tissue levels. And I do think there's a little bit of an extra line being drawn that we can't know for sure. That doesn't make it, I'm not saying it's not necessarily the case, but I would say we don't know that this is always true because, as I just mentioned, there's differences in secretor status. There's definitely differences in tissue distribution, right? Just because you have a tissue biopsy from, say, breast tissue, that doesn't mean that that's going to reflect the tissue, uterine tissue, or anywhere else. There's differences in delivery, right? Whether that's a topical, an oral, a vaginal, and how those things are metabolized in the body. And there's a difference in the solubility of each hormone. So maybe something like progesterone, the saliva can reflect tissue levels, or even, I would be more specific, breast tissue levels, as compared to estrogen in the saliva. I don't think we can always reduce things to say, aha, we've got this picture right here, which means all of the hormones are going to act this way. My brain doesn't think that things are ever that simple in physiology just based on being slapped on the hand so many times by figuring out I was wrong. And so, again, always be careful about these assumptions we're making. Okay, so during menopause, let's just remember that hormones fluctuate rapidly day to day. A person is going to look very different from whether that's estradiol or whether that's progesterone on a given day as they're going through menopause. So that's why we have kind of this large gray area to kind of see where they are within the course of that day, and we are plotting that against their own age. So what cohorts should we even use for range? We could probably spend an entire lecture on this question about reference ranges, and who doesn't love a lecture on reference ranges? But I will say, just in general, you can actually think about reference ranges and how they came to be from a couple different ways. You can use a population-based cohort, meaning I have 10,000 people that have just walked in and we ran their levels, and we can sort of do a little standard curve or a little bell curve to create the reference range. I don't think that's the best way to go about it because we don't know whether the people who came in that day are healthy or unhealthy. We haven't checked them for anything. We don't know what their health status is. We don't know what their diet is. We don't know if they're on hormones or not. So what we tend to do here is looking at questionnaire qualified healthy, meaning asymptomatic patients, to establish some of these ranges. Because here's the thing, what a lot of us want to know at the end of the day, whether they're supplemented or not, are they asymptomatic and are we managing risk? Those are really the two key components, right, from any sort of hormone intervention. And so some of our ranges actually, particularly menopausal reference ranges, include both health supplemented people and unsupplemented people together, and we controlled for healthy, right? Because if I have somebody who's just on X milligrams of progesterone or Biest, then what if they're having horrible symptoms, but they fit within that normal distribution because we put them in the supplemented group? That doesn't help me as a clinician very much. I want to know what's the right dose that's making the most people actually feel better and has having a physiologic change, reducing their symptoms, all the while reducing risk also, if that makes sense. I won't spend any more time on reference ranges, but we got to get to urine. Urine testing is super interesting, and can we use urine testing to monitor BHRT? This is a hotly debated topic. I will say, just to pause, I like the fact that being here at Genova, I'm allowed to kind of speak my mind freely around the all the different perspectives out there. One, because we actually don't have much of a dog in the fight. We do serum testing, we do saliva testing, and we do urine testing. So, we're not necessarily trying to sway any opinion. We're just trying to figure out what the facts are. But as we know, this is a hotly debated topic. Now, urine is a reflection of blood, right? Urine comes from filtrated blood. So almost all of the comparisons we've done, not just with hormone testing, but any other type of testing, organic acid testing or fatty acids and omega-3 testing, anything that comes out in the urine, we tend to have pretty strong correlations with equivalents in the blood. And so that is a really interesting thing to think of, because if one of the main messages is that you can't use blood, you can't use serum because hormones that you're dosing don't show up in serum, then I would certainly say, well, how can you make a different claim around the urine? Because those two things are connected to each other. The urine is a filtrate of the blood. So again, if you find blood to be unreliable when it comes to BHRT, I would certainly think urine you should have some skepticism around. And here's a study that I pulled. It's the results here you can see with progesterone on the bottom. It says they were used to compare. This is actually going back to that Serum study of after 42 days of progesterone, where they found it did show up in the serum. They actually said that urinary pregnenolone concentration, there was no significant difference observed. And you can see there's a trend, certainly. And even with the area under the curve, there's a trend. It went from 0.3 to 0.8, but that wasn't statistically significant. Doesn't mean it's not relevant, because we had that argument about the blood. Is a change, a small change in the blood relevant? Very well could be. So I wouldn't say this means it's not relevant in the urine. We just have to think about what the scale is. But I just wanted to bring this up here that the area under the curve study did show that, there was a trending, but nothing statistically significant. So again, I tend to focus, because we're still learning more and more about how urine reflects actual levels. What is urine testing telling you? It's always good to remember, like, urine is telling you how much of a parent hormone has been metabolized. You notice it didn't say progesterone on that previous slide in the study. It said pregnenolone. That's a metabolite. And so this is the output portion of that hormone life cycle at the bottom of this slide. It's talking about how, and this is controlled by detoxification and elimination. So the amount that's coming out in the urine is not necessarily alone, right? It's telling you how much of this has been metabolized, and that's impacted by your liver and all the other detoxification processes. So again, if you're looking in the urine, you have pregnenolone for progesterone, ketosteroids for androgens, and estrogen metabolites. So urine hormone levels represent excreted levels, and therefore urine levels are robust. I would say there's definitely a concern around tissue saturation, because if you are peeing out a ton of hormone, that means you've got a lot in your system that's going through your liver, that's being processed, and then phase 1, phase 2 ends up in the urine and is coming out. However, if the levels are moderate or low, I don't think the interpretation is as simple. We don't know whether their levels are normal because the dose, or maybe they have sluggish detoxification and they look normal, but they actually have tissue saturation, but it's not coming out in the urine, right? There's other dependencies here. One of the things that has been used in the past is 24-hour testing to kind of capture daily output as well, because we don't always concentrate all of our hormone metabolites into a given urine. We try to do a first morning void to capture most of that concentration of the overnight period. But some people pee, way more times per day than other people. And how much of that hormone and how much the liver has processed during that window is going to also change person to person. So I'd say the pros of urine testing is that it really does give you a great look at hormone detoxification. That's one of the main ways that we use it clinically, isn't it? We can look at things like estrogen detoxification to get us an assessment of risk. Certainly a lot of people want to think about doing that before they even start hormone therapy, because if somebody's not detoxifying estrogen well already, it's probably not the greatest idea to give them more estrogen to create more risk until you fix that detox pathway problem. You can also look at things like DHT production, or I would say potential DHT production, and that's kind of an indirect evaluation by making an assessment of two other hormones to say, well, because these two other hormones are acting this way, or hormone metabolites, I should say, then that means DHT activity is likely to be this. It's not the best way to think about DHT. Remember, DHT is a kind of a very highly active form of, it's a testosterone-like hormone that has its own action and is relevant in things like benign prostate hypertrophy and male pattern hair loss or hair growth. So there's other skin health and acne. DHT has its own kind of physiologic relevance. But that's one thing that is commonly assessed in the urine. And then again, you can look at androgen balance, androgen catabolic balance, or anabolic catabolic balance based on some of these kind of summations in the urine. So there are some valuable clinical insights there. And here's a common finding around BHRT urine results. What we're looking at here on the right-hand side is estrogens and estrogen detoxification. I honestly focus less on E1, E2, E3 as raw concentrations, and I'll say, all right, is this person creating more of the good products or the bad products? Dr. Pam Smith kind of talked about the good and the bad and the ugly, the good being 2-hydroxy, the bad being 16-alpha, and the ugly being 4-hydroxy. You can have a direct measurement of these on a urine test, which I think is really one of the biggest pros of urine testing. So I won't spend a ton on this. Dr. Pam Smith did cover it pretty darn well. She always does. But just very briefly, the 2-hydroxy is kind of where we want most of the estrogen to be flowing. 16-alpha has estrogenic activity. It also is a little bit interesting in that people with low 16-hydroxy, especially premenopausal women, tend to have a higher risk for things like bone loss. So there is some functionality that is at least still left to be uncovered. And then 4-hydroxy is the one that we typically want to limit because it can cause DNA damage. And here's a little graphic that we have on the front page of the Endo Plus report to demonstrate that. The 2-hydroxy showing in blue being the good, the yellow and the red emulating kind of bad and ugly, and then where that patient's result is falling compared to that healthy questionnaire qualified control cohort, going back to the reference range conversation we were having. All right, I'm running a little short on time, so we've got a couple slides left, but I want to say got a little bit from a summary. Urine hormones, I tend to think, are great diagnostic tools for assessing estrogen detoxification and risk assessment. You can get great insight around their methylation activity. You can examine the role of stress on hormone metabolism, and you focus on parent estrogens, phase 1, phase 2 metabolites. So that's really great. The method of collection must be considered because, like I said, hormone excretion is not linear. We try to capture most of it in the urine because we have that large sleeping overnight period where people are concentrating their urine, but it's not linear. So keep that in mind, especially around dosing. So what do? We've heard all this information. There's no perfect evaluation, right? There's no single test for all circumstances. It's always, to go back to the beginning of what I was saying, important to think about, what do I want to know about this patient? Is my patient in front of me suffering from andropause or menopausal symptoms where I just want to know their concentrations? Is my therapy being metabolized in a healthy way, right? That's a different question, which might point me more to the urine. Do I need to alter the dose? I would say if I'm trying to answer that question, I might look in as many matrices as I want, serum, saliva, and urine. So there's all these different questions, excuse me, and now we have one particular report that is designed to answer any or all or however specific. So the point of the Endo Plus, honestly, was to try to offer this ability for personalized testing, personalized tools to help you as a clinician tailor your clinical questions to the appropriate matrix. So hopefully this report is going to help you really hone in on some of those little nuances. And then also long-term, what we really want to do is clarify some of the assumptions. We want to know where actually the story lies. how these hormones are being metabolized at the end of the day, and where they're traveling in the system. All of those things are honestly, they're still left to be determined to some degree. As I mentioned, there's a ton of research left to be done out there. I would leave you with one take home kind of narrative is anytime you hear a very stern statement around this is what you need to do, this is the way it shows up, this is the therapy for this, always challenge those types of things that you hear as being gospel, because that's not how these systems work. We learn more and more every day how complicated systems are, which is why some of a test like this might seem kind of complicated to begin with, but it's complicated because it's evaluating a complicated system, right? Fit the tool for the question. And so that's really all I had for my time today. Hopefully you've taken away a lot of good information from this. We are always available here. There's tons of research that we have. We have a wonderful support guide that we just launched, completely fully literature cited. We have a podcast called The Lab Report where you can find more information. If you have additional questions, you can always call us here at Genova and set up a clinical consultation. And I'll look forward to even more resources headed your way in the near future. And again, I appreciate your time, and I appreciate you, being part of this journey with us. And look forward to seeing you again next week, and then in a couple weeks where we have a panel discussion. It'll be a really good time. So thanks for your participation, and we'll see you next time.
Thank you for joining us today. You'll receive a recording of today's talk in your email inbox shortly. As a reminder, you're already signed up for Module 3, Understanding the Neuroendocrine System, a novel approach to HPA axis dysfunction, presented by Dr. Christopher Moat on April 3rd.